Good evening, good night, good morning, wherever you are in the world watching this recording. My name is Mick Hughes and founder of the ACL Hub, and I've got the pleasure of speaking tonight and asking and picking the brain of one of the best in the business. Enda King is joining me from Doha at Aspetar. And Enda, great to have you with me tonight, and thanks for joining us.
My pleasure, Mick. Appreciate the invitation.
Oh, pleasure. There's probably not too many people who don't know your name, but just for those, we've got some patients who join the ACL Hub and read our summaries and get some information. So just a brief, I'll probably butcher a bio, so I might hand the reins over to you to you can explain what your role is at Aspetar and maybe some of your background just briefly.
Yeah, for sure. Doesn't mean I won't butcher it, but I'm currently head of elite performance and development in Aspetar in Doha, in Qatar. I've been here for about 3.5 years now, really enjoying it. I'll take the Middle Eastern summer over the Irish winter any year. Aspetar is an orthopedic and sports medicine centre, so a nice multidisciplinary community of orthopedics, radiology, sports medicine, and rehab as well. My role is primarily around working with my colleagues around our different clinical pathways, how we develop them, how do we treat ACL, how do we treat hamstring, etc.
Yep.
And then around staff development. And then we would have a large-ish cohort of international athletes that would come from all over the world, Australia included, to come for blocks of time from assessment and rehabilitation. So that's my primary role here. My background is obviously as a physiotherapist. I would have done various strength and conditioning qualifications as well to complement that. But I did my PhD in biomechanics after ACL reconstruction when I worked back in Dublin. I worked in a place called the Sports Surgery Clinic, very fortunate. So we had lots of pivoting sports in Ireland, rugby,
Yeah.
soccer, and obviously Gaelic games and hurling. So high training loads, lots of training rejection. So good for ACL business and good for groin business. So where I worked previously, there was two principal surgeons were doing about 1,500 ACLs per year. So a perfect hub to do ACL research. And so you see what works well or you see what doesn't work as well, and how the outcomes are influenced accordingly. So that's, I suppose, journey and work experience, and having a biomechanics lab there and also now in Aspetar has probably influenced my practice in terms of what I think is important, and where I've missed gaps in my rehab previously, and how your practice evolves over time.
Yeah, awesome. Yeah, looking forward to finding out a little bit more of, some of your experiences, both positives and negatives and lessons and things you've learned along the way. Have you actually injured your ACL before? Are you an ACL
No,
veteran that's turned into an expert?
I'm not a victim. I've had multiple groin and hip surgeries that definitely have stood me in good stead. Like I've learned lots from the process and developed some bias from the process. But we were debating this previously. Would it be worthwhile rupturing your ACL just to go through the process to get a deeper understanding? But I'm going to hold off. I think my Achilles is more likely to go before my ACL does now with my current sporting predicament. So yeah, I think not.
100%. I'm there with you, mate. That's my greatest fear. I don't worry about too much about my ACL, but my Achilles, I've got
Oh yeah.
grave fears for my Achilles. Um, Mate, you touched on it before, like you're very biomechanics. You've got great grounding in biomechanics and knowing a little bit about you as well. Very data driven and highly systematic. Can you sort of give us a brief, I guess, overview of what a patient may expect or an athlete may expect from you, day one as them turning up, and whether or not that's you actively now? Sounds like you oversee programs, but if you sort of go back a little bit into your career, earlier on in your career, what would kind of like the process be? An acutely injured ACL athlete walking in the door, what would that look like? I know that's a big question, and you may.
Yeah, it's actually, and this is something that I probably learned through mistake quite early, is being really, I suppose, beginning with the end in mind. So being really clear about what you think, and them understanding what you're going to look for to say, right, we're good to go, whatever good to go means. And that good to go really means I can go back training, and I can, there's a process
Yeah.
post discharge. And reverse engineering that, in that, right, if that's where I want you to look at the end, or where I think I want you to look at the end, what are the steps along that journey we would need to make? And now we are, let's say we're just 2 days post surgery or five, whatever else it is, or even conservative. Right. what are the building blocks we need to do over the next 2 to 3 weeks that will prepare me for my 4 or 6 week test? And then how will that lead me in? And what are the physical qualities I need to be on top of now that are going to be really important for my next stage? What do I, et cetera, et cetera. And
Yep.
that does two things. It means that there's multiple qualities you want to develop concurrently through ACL rehab. That pie chart changes as the process
Yep.
goes on. So obviously settling the knee down and inhibition is very important at the beginning. Strength, power, mechanics more at the end, and conditioning, etc.
Mm.
But my mistakes have been where I was waiting too long to bring certain qualities in. So I
Yep.
wasn't preparing each phase as we go along now. And the biomechanics lab then telling me, right, you didn't do what you think you should do. And then secondly, shifting the goalposts on the athlete, telling them that I need you here. And then they get there and you think, actually, no, maybe I need a bit more. Or you
Yep.
said if I could do this, I'd start running. Yeah, but your knee's still a bit swollen. So having that structure has really helped my practice.
Yep.
It's really helped. Like we have 90 physios here in the rehab department in Aspetar. It's not that there's a right way and wrong way of doing it,
Mm.
but we need kind of the same milestones and the same goalposts, and then you'll have different strategies, and there's various ways of rehabbing an ACL at every point.
Yep.
But also every ACL is a bit different. Depends on the graft, depends on the injury history. Some people knee blows up, some knees are very quiet very early on.
Yep.
So, having that stepwise approach to things, for me, make sure my rehab is consistent. For us, make sure our progression is consistent. And for the athlete and then for the patient, it gives the confidence that I can see the journey. So even though I'm at the beginning, I can see the map. But it also, when you're talking about fear of re-injury, one of the big things is self-efficacy. And as they get further on, they can see, well, I've achieved this and I've achieved this and I've achieved this and I've achieved this. And therefore, naturally, the most obvious thing now is to start jumping or to go back to train, etc. So, if I could do only one thing well the first time I meet an athlete,
Mm.
it would be to map out that journey
Yep.
and to map it out repeatedly for them on a periodic base after that. And I think it keeps me focused and it keeps them bought in and targeted over each of the rehab blocks that come afterwards.
Yeah, that's awesome. And beyond that first, I really like that approach, and that's certainly, reading your work and listening to you as well. It's certainly, and having I guess the luxury of sort of learning a lot from little bits of nuggets from a lot of experts in the world. I've certainly taken that reverse engineering approach myself, and I find it does work bloody well. And for you beyond that first month, would you say, or what would be kind of like your regular check-in points? Are you sort of constantly assessing like weekly, fortnightly, monthly to sort of make
Yeah.
sure they're on track and to stop and actually get on the front foot if you do see a little dip in their performance, or if you're seeing things, what would be your regular touch points, I guess, from an objective measure point of view?
Yeah, they'd probably change depending on the quality. So, for example, I mean, clinically, you want your knee settling every week.
Mm.
Monday to Tuesday, hard to tell. Friday to Friday, I should see whether that's range of motion, whether it's inhibition, whether it's, knee swelling. If they're not tracking, they're going to cause you a stone in your shoe
Yep.
as you progress along. Yes, obviously you'll respond to how they feel the morning after particular sessions. It'll give you feedback on that. But in terms of formal tracking, clinically, I would be looking at things on a weekly basis.
Yep.
Motor control wise, the generic patterns that we can all see, but subjectively we might mark a little bit different. Again, I'd be judging them every kind of 2 weeks. What's your squat pattern like? What's your hinge pattern like? What's your calf pattern like? And maybe some of the running mechanics on the treadmill as we get on. Week to week changes are a little bit tricky, but every 2 weeks you should be starting to see nice, observable
Yep.
differences between them. And then the other qualities like strength and power and plyometrics, I probably wouldn't formally test them any more regularly than once a month,
Yep.
because it takes time to develop strength. It takes
Yes.
time to develop these qualities, and so so we would do them every 6 weeks here in Aspetar, but anywhere between 4 and 6 weeks, because you could get a natural periodization where you drop off on that fourth week and then test at the end of the week.
Yeah. Yep.
I think that's far enough apart to track progress, and far enough apart that you can do a block of work and then judge your block of work on what you've done from there. And obviously,
Yep.
you'll know if your weights are not going up on your knee extension machine or your leg press or whatever, that'll be a good surrogate for how you're tracking or not tracking. But there are times when I've put the weights up in a leg press and I've gone back and done an isokinetic and the quad strength hasn't really changed because of the technique I was using or the other rep ranges or what I was doing. So
Yep.
I think. Yeah, I think your clinical is very regular. your motor control is semi-regular, and then your strength power, the big and high intensity ones,
Yep.
periodically every 4 to 6 weeks. Probably not any longer than 6 weeks, because like we all
Yes.
start to lose our way a little bit. I
Mm.
think we need to hold ourselves accountable to what we're doing. And some of the argument sometimes is, yeah, but we're losing a few days to testing, but we're losing more days if we don't realize that we are or not tracking where
Yes.
where where we need to track. So yeah, that'd be the general rule of thumb.
Yeah, no, that's good. The strength power and plyo is very, objective. You can get some really, really clean numbers there, I guess. And question just thinking out loud here, like your squat patterns, hinge pattern, calf patterns, to you, like, is that more of like is that like the athlete's eye and the coach's eye, or is there like an objective? Is there like a tool that you use to measure that, or is that just based on your own experience? Just for the clinicians out there that may.
Yeah, I think you definitely can measure it. There's a number of ways. In the biomechanics lab, we would use a lot of those assessments are early stage, so we wouldn't do the full Vicon mocap for that, but we might use Noraxon sensors. So you get a knee flexion angle, okay, you'll get a squat depth, you'll get ground reaction force asymmetry at the bottom of the squat. So you could do it on a force plates, or you could measure your knee angle either with sensors or with a camera.
Yep.
Which takes a little bit of time. Now you can eyeball it as well, but if you wanted to be objective across or between the group, that
Yes.
would be a good way of doing it without having of course, you could fully marker up for that as well.
Yep.
We also do a step down where we're looking at the impact forces when you're stepping down off. So if I had in the early stages, if I my right is my operated side, when I'm stepping down with my left leg, I'll normally have a higher peak because I'm not
Yes.
able to control that descent. So
Yep.
again, it's a nice surrogate for what my eccentric control is on that side. The frontal plane is difficult to measure both with sensors and with the camera.
Yep.
So, I mean, you would eyeball that, and you would eyeball it throughout the chain. So, a little bit what's happening at the trunk, a little bit
Yep.
what's happening at the knee, and a little bit what's happening at the foot.
Yep.
And it could be little at all three, which actually is a lot when you think about the knee
Yeah.
valgus moment. That would be accordingly. So,
Yep.
again, it's difficult. So, there's probably a qualitative element to that.
Yep.
But the other ones, you can choose to either eyeball it, or you can
Yep.
quite easily objective measure. And I think for our ACLs, definitely the knee flexion angle in the squat
Yes.
is the big one, and the ground reaction force asymmetry. I think they would be the two easy, you know, ones that would track really well as your progress is coming along.
Yep. And have you seen like a really clear link there between quad strength, hip strength, or calf strength, or hamstring strength, and that ability for knee flexion? Are you seeing like a clear pattern that it's related to quad, or is it related to something else?
Yeah,
And for example, you strengthen the crap out of your quads, all of a sudden magically your knee flexion angle goes up.
yeah, it's predominantly quad strength.
Yep.
I'm going to make it up, but let's say 80/20. It's
Yep.
80% improvement in quad strength, 80% improvement in clinical. How happy is your knee to go into those knee flexion positions, even for a hamstring graft? And then it's kind of 20% patterning. Are they happy letting the knee come forward over the toes?
Yep.
Are they happy redeveloping that pattern that might be so they might look quite good on an open chain isometric or isokinetic, and then still not be happy letting that tibial translation come with it. But I'd say that's
Yep.
the big piece is if your quads are strong and your quads at depth are strong,
Yep.
then you should see a fairly linear relationship with your knee flexion angle on that squat.
Yep, which is why we bang on about the quads quite a lot in ACL rehab. Do you see the patella tendon struggle a little bit more than hamstrings, or throughout the journey, you're seeing a graft type kind of get out of the blocks a bit better and struggle a bit later, or vice versa? What's your I guess experience with different graft types for those that are managing a few different
Yeah,
variations?
I think we're all biased by what we've seen. So like when I worked in Dublin, it was 90% patellar tendon.
Mm,
So you get good at patellar tendons because
yep.
if you don't get good at them, you don't see many of them. So like I know there's been a shift towards hamstring and even quad tendon, but like anterior knee pain's a rehab problem. It's not really a surgical problem. The
Mm,
graft, every graft has a consequence, and so
yep.
how can you find a way to settle that down? But like you say, if you have a patellar tendon or a quad tendon graft, you're going to have more quad weakness than if
Yep.
you have a hamstring graft, which will influence the sagittal plane in those first 12 to 16 weeks more in those anterior grafts than posterior graft. What's interesting is I've seen far more quad tendon grafts here than I would have seen previously in Dublin. And you get a lot of VMO inhibition from them,
Yes.
far more than I was expecting, in spite of, not necessarily that painful, but lots of VMOs that making the terminal extension quite difficult, making your running mechanics drills and your pogos quite difficult, far more than I was expected. And that's been a real work on for us. And secondly is you can get quite a bit of irritation of the quad tendon in those knee flex positions. So as you go to progress onto your acceleration mechanics, or your split lunge drills, etc. So again, we've been very proactive now in our quad tendons. VMO is number one, and then loading that quad tendon in a knee flex position, whether that's lying on your tummy,
Yep.
or a reverse Nordic would be too
Just not.
aggressive, but the similar type of exercise interventions, maybe a Thomas test position, and just
Yes.
doing isometrics, and just to get some of that stimulus in the lengthened position.
Yep.
That's completely cleaned it up, but it took a few for it to be recognized that actually no, it's different than a patella and different than a hamstring and what it
Yep.
goes. And then the hamstring graphs are definitely, I wouldn't say everyone, but lots of them get the sniper at 4 to 6 weeks where they go to take their shoes off and
Yep.
have a little tweak. I think the big challenge there is that the medial hamstring is very hard to keep it the same.
Yep.
Inner range knee flexion is difficult. That's more a functional problem than, let's say, a knee pain or a clinical problem.
Yep.
And you often get huge compensation to the semi-mem in particular, but
Yep.
also to the biceps femoris and that outer range. So you get more kind of functional challenges or strength power challenges with the hamstring stuff. And
Yep.
then the clinical stuff is definitely more with the anterior knee side of things. So out of the gaps, often the hamstrings are quicker. In the
Yep.
later stage, give me a patellar tendon any day of the
Yes.
week.
Any day of the week. Agree. Agree.
Be the
Wholeheartedly
preference. Yeah.
agree. Yep. Um, Now moving on, like one of your more recent papers certainly has challenged the 9 month return to sport mark. That's kind of the 9 month figure has sort of been lingering around for about ten years now as a bare minimum time frame. And your recent paper has certainly challenged that. Can you give us some insight to what you guys learned and what
Yeah.
where I guess where you stand at the moment? Is it do they and professional athletes, right? They're obviously got different bigger beasts to sort of manage rather than just passing the 9 month. They've got their external stakeholders and whatnot. So
Of course.
yeah, would love to hear your perspective on that.
I think if we come back to the base question here, is regardless of what level you're at,
Mm.
from a timeline point of view, does it matter when we return? And so, if we look at Rula's lead paper there, what she showed was those that passed the criteria of whatever strength and control that we had here over a period of time. Those that passed their criteria, the re-injury rate and the contralateral injury rate was no difference whether you went back before 9 months or after 9 months. So if you finished rehab, it didn't make a difference. So, is rehab the most important part or is time the most important part? I think certainly the time element, I would strongly question for a number of reasons. Number one was, I mean, Donald Shelburne had a paper over 15, 20 years ago saying after 6 months, it made no difference in re-rupture rate.
Yeah.
Where I worked in Dublin previously, we had our 2 year follow-up on a cohort of 1400, and if you return from 6 to 9, 9 to 12, and 12 to 15, there was no difference in contralateral or re-rupture or ipsilateral. And actually that group have just had their 5 year follow-up, and
Yeah.
over half the second injuries were after 2 years.
Yeah.
So for me, whether you hang on for time, whether you don't hang on for time, it has no influence on your doesn't mean you're physically ready or not, but the time from surgery definitely doesn't indicate. And we know the graft maturation can go on for 2 years, but like no professional athlete is hanging on for 2 years to return to play if they
Yeah.
have a choice. After
Yeah.
ACL record, and many of them, succeed very, very well.
Yeah.
I don't know the official AFL numbers, but the European football numbers are 7 months is
Yes.
the average for return, and re-injury rate of 4% at 5 years. So,
Yeah.
I think, yeah, definitely. And the challenge a bit is, I know part of this 9 months was around a paper in the BGSM, but the problem was that only 10% of the injuries in that cohort were ACL. The other 90% of re-injuries actually were not ACL injuries.
Yeah.
Um, so I think it's been, to be fair to the authors, it's been a misinterpreted paper
Yeah.
that has been maybe used by physios or by surgeons as a way of buying time.
Yeah.
I'd say misinterpretedly in terms of that paper, but from an academic point of view, there's many other papers that suggest that time post surgery will not predict. Doesn't mean it's not important, but it will not
Yeah.
predict who's going to go on and have a second injury and who won't.
Yeah. That's really fascinating. And so, do you think part of it also too relies on the rehab quality, like knowing that your group of 1,400 people that went through Sports Sanitary Clinic in Dublin would have had some really high quality practitioners look after them? Compare that to, we're looking at this data that comes from largely cohorts in the States where we're seeing, 30% re-injury rates in 2 years in relatively, I guess, non-elite populations with very questionable rehab quality tied
Yeah.
into it and around it. Do you think that's probably where some of the waters get a bit muddy? Um,
Yeah. I think definitely in terms of consistency of outcome, it does. Like, I mean, again, just because you test very well,
hmm,
whatever very well means, doesn't mean that we like in my own PhD work and even with Rula's work as well, like just because you passed or didn't pass the criteria, I can't say if you do good or not in your test, you're going to go on to have an IPSI or contralateral injury. So I think we always have
yeah,
to keep that closing. I do think there's certain things we don't measure well.
yeah,
That like if you have a very comprehensive rehab program, yes, we don't measure movement that well on general. We keep an eye on it, but we don't measure the way we measure jump height and strength
yeah,
in most institutions. And then secondly is that bridge of reconditioning the athlete. So it's one thing to be able to hop and jump, but feeding them back into their environment in an incremental manner to the demands of the sport. And
yeah,
that's what you definitely don't get in a recreational environment. It's all or
yes,
nothing. I'm either in or I'm out. And when I'm in, I'm all in again with no warm up and whatever else that goes with it. So I think there's a couple of factors to that.
yeah,
I think that it's the standard of preparation will definitely, and it goes back to the prevention programs. Like
yeah,
prevention programs reduce it by half in multiple populations in multiple different countries. So whatever you do physically has an influence on things.
yeah,
So definitely the standard of rehab should have an influence on things. The challenging part for that is that when an athlete says, "Can I go back or not?" at a high level, I can't say, well, that was good enough or not good enough, or you will or you won't. Now,
yeah,
part of that is statistics because 95% of the time they'll be fine. So if I say no, I'll be right 95% of the time. And in the casino, that's good enough for me. Um, and because we don't have enough re-ruptures, thankfully, anywhere in the world. And probably the only way we would do that properly is with a large multi-center. So
yeah.
um, rehab is a big piece of the jigsaw.
Yeah, yeah. Well, that's really really fascinating insight. And I hadn't heard about those, 6 to 9, 9 to 12, and beyond, and to hear that sort of high re-injury rates beyond the 2 year mark was yeah, news to me. So that's really interesting to talk about. The talking about contralateral injuries, they're a huge headache. Like to also to us as clinicians, they're a huge mental hurdle for our athletes that have to go through the whole process again within a year or two. Do you have any I guess strategies in place from day one to look after the contralateral limb? Cross education's quite conflicted at the moment. Do we train the healthy limb to get the best out of those little 1%ers out of the ACL limb? Yeah. What's your approach there to try and keep the healthy contralateral limb in play as
Yeah.
successfully and as long as we can?
Yeah, I think I agree. It's a real challenge. Like, and it's almost half of our second injuries are the opposite side. It's nearly 50-50, if not more, on the contralateral side, 2 to 1. But I think if we look about, how does contralateral injury mechanism occur? I'm biased a little bit by my previous research in that when we looked at those that went on to rupture their healthy limb, none of the asymmetry measures were able to identify who would go on to. So I was assuming large quads asymmetry or large knee extension moment asymmetry. Therefore, I will bias my contralateral side. Therefore, I will. But none of the testing could predict. Sorry, none of the differences were any asymmetry differences. I
Yeah.
think where we can have a positive influence again is in the neuromuscular system. Number one, obviously, is in frontal plane control. So we put a lot of effort into the operated leg and maybe the motor control aspect, the strength
Yeah.
aspect less so because the operated leg is nearly always playing catch up. But if from a
Yes.
motor control point of view, in the frontal plane, bringing the contralateral side with us, but especially the nervous system, I think. Plyometric exercises and high level plyometric exercises, like the one insult that the contralateral limb definitely has is a drop in the nervous system.
Yeah.
Like it tends to keep its muscle mass if you do anything at all. Certainly, it doesn't have any of the structural challenges that the operated side knee has. But you will see a drop in plyometric ability. And in terms of having, stiffness or activity prior to ground contact to control the knee, in terms of the sagittal plane controlling that anterior translation, I think having a very robust uh, overall level of plyometric ability and having good symmetry
Yeah.
would be very important for me. Or sorry, that's where I would put an additional focus
Yeah.
on my contralaterals because my PhD work showed that it's difficult to predict contralateral injury, but all those in the contralateral group were less plyometric on that healthy side than those that weren't. And so therefore, intuitively, the springier you are, the more activity you have prior to ground contact, the better your performance, but
Yeah.
also the more likely you will be able to protect that
Protect.
quality. And it's the one thing that will definitely detrain on that operate. It's on that healthy side.
Yep. Good, great insight there too. That's plyometrics for the win. Always. Healthy injury prevention programs must have them, ACL rehabs. But knowing what we know too, and meeting so many people along the way, they're often the most missed element
Yeah.
to a non-elite setting. Like, they would be so commonplace in our elite environments. It'd just be, it would just be done. In our
Yeah.
non-professional worlds, it's shocking how many people walk in. You talk about strength, you talk about the rehab qualities you've done, you hear about the struggles they've been through, and it's like, okay, do you even do any basic sort of skipping work? Do you do pogos? Do you even just do a box jump? Like, are you doing anything
Yeah.
like that? Not that it's technically a plyometric, but the absence of that stuff is just so
Yeah.
far widespread. But it can help a hell of a lot of people's outcomes. So yeah,
No, I agree with that. I agree
clinicians,
with that.
patients listening to that, plyometrics for the win. Um, Before we've probably just got a few minutes left. I know a few people have asked this question, and it may not be a very simple answer. There's always a few, I guess, caveats to this kind of question. But if you were to pick a handful of objective measures for return to running and return to training slash return to sport, what would be, I guess, the tests that you would perform, and I guess the top, 3 to 5, and kind of like the targets that you're wishing for the athlete to
Yeah.
hit.
I think I'll start with the last and then I'll come back to running. I think if you're applying a general rule of thumb, like measures of isolated quadriceps and hamstring strength will be important.
Yep.
Whether you do that isometrically or whether you do that through some other means. You can hide sometimes on your squat RMs or your leg press RMs. So I think if you're looking to clear someone back to train. I think the isolated measures are important. The counter movement jumps are important, especially for the eccentric capacity.
Yep.
So you'll see eccentric velocity drops. You'll see reduced eccentric impulse. So we're always good at focusing on the jump height, but maybe not so much the depth. And like everything else, you see what you look for, and you look for what you know. And now that the force plates are becoming cheaper and more available and more readily spread, people are more aware of what they do and do not see side to
Yep.
side and overall capacity wise. If I could pick one test, it'd be the single leg drop jump
Yep.
because that one always seems to lag behind your strength and lag behind your counter movement jump. Um, the drop jumps are more demanding on your knee extension moments than the counter movement jumps, but also the horizontal jumps. Let's say your hop for
Yep.
distance. So if you have gone back to our talk about how important plyometrics is, if you have plyometric deficits or you've knee extension moment deficits, you'll nearly always see them a little bit in those drop jumps.
Yep.
I would add change direction and running on top of that, but they're often underpinned by the previous three.
Yes.
And there's a lot of coordinative strategy to it. We've an instrumented treadmill here the last 2 years in Aspetar, and again, it's amazing when you don't measure stuff what you assume that just ain't so.
Yeah.
And so people with quite good quad strength, quite good jump performance, and ongoing ground reaction force asymmetries, which is not normal. Like all of us, no matter how ploddy a runner we are, we tend to have very, very, very tightly knit
Yep.
ground reaction force asymmetries and large knee extension moment deficits accordingly. Now, again, some of that will pick back into the eccentric velocity and eccentric moments and the counter movement jumps, but um, I think that they're the big things to have a look at
Yep.
is to your underlying qualities, but then your mechanics of running and change direction, which you can do very easy with an iPhone. You'll pick
Yep.
the big trunks way, you'll pick when they don't want to flex their knee,
Yep.
and you'll pick the pelvic drop in mid stance and running. So I think those would be the main ones. And in terms of going back to running, then we would have clinical and testing criteria. The running pathways that they would because we have it, they would start water running or underwater running,
Yep.
progress to Ultra G. So a lot of when you're talking about go back to running, the question is, well, what is a run and what's your first run? And therefore you can only define your criteria when you pick what. So everyone says they're going for a run. Someone does 4 laps the pitch. Someone runs from here to the far end of the court, and they've both gone for their first run. So whatever it is, you just need to define what your run is. So if our run is 200 meters intervals on the treadmill for 8. That's just a first run at 10, 12K an hour. You could call it 6K an hour run if you wanted, but it's just a line in the sand.
Yep.
And so we'll have finished our underwater treadmill protocol, our Alter G protocol, which are really just changing body weight through
Yep.
the same kind of metrics over time with intermittent longer bouts of running. We'd want you to be able to do a single leg pogo with good form
Yep.
and no knee reaction because running is hopping from one foot to the other. And generally speaking, we're looking for your strength and jump symmetry to be around 70% or so,
Yep.
only because lots of people can go back running without that or
Yes.
with less than that. But you don't want your running to get away. It's much easier to hold an athlete back a little bit and progress slowly than it
Yep.
is to go forward and then have to row back a little bit. So we
100%.
just want to make sure that, I mean, when you start running, your next goal is to start change direction and get on field.
Yep.
And if I have, 65% and I'm looking for 80%, I'm not going to make 25% of progress in a 4 to 6 week block, no
Yeah.
matter what pharmaceuticals I introduce to the situation. Um, so I think going back to that expectation management and not moving the goalposts, it's much easier to keep someone on the alter G for a week or two.
Yep.
They're happy, they're running, they're getting their stimulus. We're building up their chronic load and cardiovascular while we add on the extra bit where it's needed, so that again all of these qualities are coming concurrently, as opposed to like I've seen people with 85% quads symmetry whose knee gets a bit sore when they go back running because they couldn't hop on one foot. So
Yes.
like it's just making sure that the parallel competencies are coming together.
Yeah, yeah, great insight. I think that's probably where a lot of junior clinicians may kind of just get caught up and a bit lost, where they do have everything blocked and segmented. That we're just focusing on strength only, and then all of a sudden, okay, we've got some good strength, and all of a sudden, okay, now it's going to do a plyometric block. We know that a lot of this stuff can coexist, and it also needs to coexist and come along for the ride. There's a lot of things that absolutely can and should work well together, not just stand in silos. And you've been absolutely fantastic and so insightful, and I know you're a very busy man. I just appreciate, yeah, your absolute open book knowledge tonight, fountain of knowledge. And I just want one more thing before you go. Is young clinicians who are out here listening tonight, what would be, I guess, one clinical pearl you could give them in their ACL management, or even clinician, just it doesn't have to be
Yeah, yeah.
ACL specific.
I think
Anything that would make them a better clinician moving forward.
I would say, and it's not always easy to do this, so I put an asterisk beside it. But any luck I've had in developing mistakes or a legacy of mistakes in ACL is because I was working places that there was lots of ACLs. So if you see one ACL a year, it's very hard to get good at ACL. It's very hard to get good at anything. So I mean, have you the opportunity to work where there's a lot of them? And have you the chance to work with a team, whether that's orthopedic or from a reconditioning team? Can you work where there's either multiple physios or definitely the strength and conditioning coach, because they just have different eyes on it. It's just so interesting to get different opinions, and we become siloed by the athletes that we've seen personally.
Yep.
So I had this experience, I had this experience. It's obviously different than your experience, making. So together, there's much more learning in that. And
Yes.
then number two is how an S&C coach interprets a counter movement jump versus how you do it. You
Mm.
start to get very nice insights in it. So I think if you want to get good at them, it's a volume component, number one, and number two is it's who you're working with. So like we have 200 ACLs here a week in Aspetar we're
Yeah.
rehabbing. Like if 10% of them are tricky, that's 20 tricky ACLs a week.
Yeah.
So if you have a group of people who are open and looking to share stuff, I don't need to have a problem before I can learn from your tricky one and then
Yeah.
take that learning into my next coming forward. But
Yeah.
again, that it's we all work where we work. It's if I'm aspiring to think about how career wise where would I go, or if I had aspirations, that's where I think it would really, that's what's paid me dividends at least.
Yep. Yeah. And that could be an example. Like if you got an interest in shoulders, you got an interest in hips, you just got to be around that sheer volume. I think
All the same.
that message there is really strong, regardless of your area of interest. And that's what I found working in the luxury of working in Melbourne, in the sporting, arguably the sporting capital of the world, with the amount of wonderful sports, but unfortunately, a sheer high volume of ACLs that was happening each year. That's how you sort of get that experience and how you get good at it.
Yeah,
And thank you so much. Wonderful picking your brain, and yeah, thanks once again for all your open honesty, transparency with all your questions, and yeah, well, looking forward to hopefully catching you at SMA this year if I can get a lead pass from the family.
absolutely. Thank you, Mick, and thank you for all you do, producing huge resources all the time and sharing knowledge. So it's greatly appreciated, and it's an honor to contribute.
Pleasure, pleasure. Thanks, Enda. We'll
Thank
catch you
you.
next time, mate. And thanks everyone for listening tonight.